Okay, nitrates are excellent antianginal drugs are used frequently to relieve chest pain in patients with stable angina pectoris and acute coronary syndrome. Nitrates are primarily vasodilators and dilate veins and arterioles and coronary arteries by relaxing vascular smooth muscle cell. Although nitrates acts as vasodilator and coronary vasodilators, therefore the primary anti-ischemic effects are due to systemic vasodilation rather than coronary vasodilation. So systemic venodilation lowers preload. Systemic venodilation lowers preload and left ventricular and diastolic volume and reduces myocardial oxygen demand by reducing wall stress. Nitrates also cause arterial and arteriolar vasodilatation, although to a lesser degree, and can decrease systemic vascular resistance and blood volume. The fall in the systemic blood pressure reduce wall stress. The fall in the systemic blood pressure reduces wall stress, which leads to further decrease in myocardial oxygen demands. Okay. Looks like Baker's cyst, isn't it? Osteoarthritis. Like a non-pulsatile mass is palpated in the popliteal fossa. Non-tender pulsatile, sorry. Non-tender. So not Baker's cyst. Non-tender pulse. Sleep. That's more fun than the car. Okay. Okay, it's a popliteal artery aneurysm. Popliteal artery aneurysm are the most common peripheral artery aneurysm. They occur predominantly in men and have a similar risk factor as other large vessel aneurysm like smoking, hypertension, advanced stage, although they are usually asymptomatic and discovered incidentally. Popliteal artery aneurysm occasionally cause tibial nerve compression or ischemic complication like thrombosis, distal embolization, or intramural thrombus. The diagnosis is made with duplex ultrasonography or CT angiography. The aneurysm that are more than 2 cm in diameter or symptomatic are referred for surgical repair due to the risk of complication like rupture or thrombosis. Patients with a popliteal artery aneurysm are at significant risk for coexistent aneurysms, especially of the contralateral popliteal artery, 50% of the patients, and the abdominal artery, and the iliac or femoral vessels. So, patients with popliteal artery aneurysm are significant risk factor with coexistent aneurysm like contralateral popliteal artery, abdominal aorta, or the iliac or femoral vessel. Therefore, it is recommended that in addition to complete preoperative imaging to the ipsilateral leg, screening of the contralateral leg and the abdominal aorta should be performed, typically ultrasonography. CT or MR angiography can also be used. Imaging should be completed prior to repair of the popliteal aneurysm because surgical planning is affected by the extent of the aneurysmal involvement. Why we are not doing the B carotid ultrasonography? Extracranial carotid artery aneurysm are uncommon. In general, less than 1% of all arterial aneurysm and are also not closely associated with popliteal artery aneurysm. In contrast, in contrast to abdominal aortic aneurysm, routine ultrasonographic screening for extracranial carotid aneurysm in patients with popliteal artery aneurysm is not recommended. And it's not Marfan where we get fibrillin Marfan for fibrillin and slit examination, slit lamp examination again with the Marfan. An ulcerated infection with Treponema pallidum can result with tertiary syphilis and cardiac involvement may comes with aortitis. So it is not the answer. Okay, next. During the operation, after is post operative. Yes. Okay. Many patients with HOCM, hypertrophic cardiomyopathy, have dynamic left ventricular outflow tract obstruction that, when severe, can drastically limit the cardiac output. The degree of left ventricular outflow tract obstruction. The degree of left ventricular outflow tract obstruction is by low volume, worsened by low blood volume. Therefore, hemodynamics should be optimized. Therefore, hemodynamics should be optimized to encourage the blood high left ventricular blood volume throughout the cardiac cycle, that is both end diastolic and end systolic. Okay. High left ventricular high left ventricular end diastolic volume, high preload is encouraged. High left ventricular diastolic volume or high preload is encouraged by adequate hydration and avoidance of venous dilator like nitroglycerin. Maintaining a relatively low heart rate is beneficial uh, as it lengthens diastolic filling time to increase the end diastolic volume. High left ventricular end systolic volume is encouraged by a relatively low stroke volume. A relatively low stroke volume, whether from low contractility or high afterload pressure that the left ventricle must contract against, lead to blood being ejected during systole at a higher left ventricular blood volume. The higher left ventricular blood volume minimizes the left ventricular outflow tract obstruction, allowing for more effective cardiac output. In contrast, if end diastolic volume gets too low, there is precipitous drop in systolic volume, leading to severe left ventricular outflow tract obstruction. So main thing in here, like we need to high preload, and high preload is encouraged by adequate hydration before operation starts. We give some amount of fluid to hydrate the people to actually it is given not to drop the blood pressure suddenly, and we will avoid the venodilator like nitroglycerin. And okay, beta blocker are highly useful in treating HCM because they decrease the heart rate to lengthen diastolic filling time and increase left ventricular end diastolic volume, and they decrease the left ventricular contractility to increase the left ventricular systolic volume. These effects help minimize the left ventricular outflow tract obstruction. And we will not gonna give the dopamine or norepinephrine. Norepinephrine stimulates alpha and beta receptor, the peripheral vasoconstriction, resulting in increased left ventricular afterload, and are beneficial for left ventricular outflow tract obstruction in HCM. But the increased heart rate and the contractility worsen the obstruction and outweighs the positive effect. Got it? Oh, I have read the norepinephrine. I haven't read the dobutamine. Dobutamine primarily stimulates the beta 1 receptor. The increased heart rate and contractility caused by beta 1 stimulation actually decreases the left ventricular end diastolic and left ventricular end systolic volume. That means preload afterload. It decreases the preload afterload respectively, and can worsen the left ventricular outflow tract obstruction in HCM. So dobutamine can worsen the left ventricular outflow tract obstruction in HCM by decreasing the preload, by decreasing the afterload. Okay. Okay, it's the syncope. It is a like cardiac syncope. Okay, if we go through the box, there are three types of syncope: reflex syncope, orthostatic syncope, and cardiac syncope. Reflex is vasovagal, situational, and carotid hypersensitivity. Vasovagal is like it might trigger like emotional stress, prolonged standing, and prodrome is nausea, warm, sweating. And situational can happen during micturition, defecation, swallowing, coughing, and carotid hypersensitivity is tactile stimulation over the carotid sinus while standing, tactile stimulation of the carotid sinus while standing, and advanced stage and carotid atherosclerosis. So orthostatic syncope is due to medication like vasodilator, or if you use inotropic, vasodilator, alpha blocker, prazosin, antihypertensive, and inotropic beta blocker, hypovolemia, history of volume loss, consistent volume loss, and autonomic dysfunction like advanced stage, and predisposing factor like diabetes mellitus, Parkinsonism can cause orthostatic hypertension. Sorry, orthostatic syncope, and cardiac syncope due to left ventricular outflow tract obstruction, ventricular tachycardia, and conduction impairment. Left ventricular outflow tract obstruction, syncope with exertion, systolic ejection murmur, and ventricular tachycardia. There may be no warning symptom, cardiomyopathy, ischemic heart disease, and QT interval prolongation, and conduction impairment preceding fatigue or lightheadedness, ECG abnormality. Okay, now syncope is a transient loss of consciousness accompanied by a loss of postural tone with a spontaneous return to the baseline neurologic function. So, transient loss of consciousness accompanied by loss of a postural tone with spontaneous return to the baseline neurologic function. It occurs due to global hyperperfusion of the brain and can have many causes. Okay, these patients' syncope is most likely cardiac arrhythmia, finding consistent with arrhythmic etiology in the patients in these patients including following: sudden onset and lack of prodrome symptom occurrence while the patient was at rest and seated, no change in the position, evidence of underlying structural disease, prior myocardial infarction, murmur, MR, and presence of frequent ectopic beat frequent ectopic beat. The most common arrhythmia causing syncope is ventricular tachycardia, which is potentially fatal. Therefore, these patients should be admitted to the hospital for continuous ECG monitoring and further cardiac workup, that is echocardiography. Got it? Okay. Okay, this patient has life-threatening TET spill of the tetralogy of the phallus. The main thing in this question, like auscultatory finding, like auscultation reveals a single S2 and a harsh crescendo decrescendo systolic murmur heard is that is heard at the left upper sternal border, so looks like pulmonary stenosis. Okay, that tetrad of these TET spell, like tetralogy of Fallot, is right ventricular outflow tract obstruction due to pulmonary stenosis, right ventricular hypertrophy, overriding of the aorta, and the VSD. These presentation depends on the severity of the right ventricular outflow tract obstruction. The presence of pulmonary stenosis or atresia, the presence of pulmonary stenosis or atresia and infundibular spasm restricts pulmonary blood flow. In addition, exertion, feeding, agitation, and increased pulmonary vascular resistance, resulting in complete right ventricular outflow tract obstruction. The diversion of blood from the right ventricle, the diversion of blood from the right ventricle into the aorta instead of pulmonary artery results in acute hypoxemia and cyanosis. That's well. Although clinical findings is harsh crescendo, decrescendo, ejection murmur over the left upper sternal border due to pulmonary stenosis. The single S2 comprises the normal aortic and the inaudible pulmonary components. Acute management involves knee chest positioning to increase systemic vascular resistance as well as inhaled oxygen to stimulate pulmonary vasodilatation and systemic vasoconstriction. These mechanisms promote uh, right ventricular blood flow to the pulmonary artery instead of aorta. Okay. Do you want me to read the other options too? When they do the knee chest position, it actually increases the systemic vascular resistance. So what happens when they do knee chest position, the like what happens from right atrium, blood goes to the right ventricle, from right ventricle blood goes to the pulmonary artery to the lung. Isn't it the pathway, pulmonary artery to the lung? So if it bypasses, what happens in this condition, that instead of going the pulmonary artery, they actually goes through the aorta. So right ventricle contains deoxygenated blood. If deoxygenated blood goes through the aorta, then there is admixture of these deoxygenated and oxygenated blood, and thus causing the cyanosis. So if if they do knee chest positioning, it will increase the systemic vascular resistance, so the blood will flow the normal pathway, like from right atrium to right ventricle to the pulmonary artery instead of going the aorta. And that's why uh, the hypoxemia or the mm, complaints actually uh, relieves, some sort of relieves by this knee chest position. Got it? Knee chest position actually increases the systemic vascular resistance, and it will stimulate the pulmonary vasodilatation and systemic vasoconstriction. Just look at the picture, uh, look at the blood. Yes, from right atrium, the deoxygenated, the blue bloods comes to the right ventricle, and these blue bloods actually goes through the pulmonary artery to the lungs. It is the normal pathway, but as there is a um, like VSD, ventricular septal defects, so these deoxygenated blood can't go through the the pathway of the aorta, and then the admixture can happen, and then cyanosis develops. So when there is increased systemic vascular resistance, then these pulmonary channel actually opens, so blood flow normally, so admixture decreases. Yes. Okay. Abdominal aortic aneurysm is generally defined as the enlargement of the abdominal aorta to a diameter more than 3 centimeter. So abdominal aortic aneurysm is defined as enlargement of the abdominal aorta to a diameter more than 3 centimeters. So abdominal aortic aneurysm, 3 word. So if it is more than 3 centimeter, that is significant. 3 word more than 3 centimeter. Okay. A rupture is more likely if with large aneurysmal size. Rup but by far the definition concern, if it is more than 3, that is abdominal aortic aneurysm. If rupture is more likely if the aneurysm size is more than 5.5, or a rapid rate of expansion more than 1 centimeter per year, and primitive preemptive surgical repair is the definitive treatment. So main thing is, if it is the aneurysm size is more than 5.5, or a rapid expansion more than 1.5 centimeter per year, surgical repair is the definitive treatment. However, surgery carries a relatively high risk of complication, with the risk of repair typically greater than the risk of rupture until the aneurysm reach the larger size. Therefore, management of small to moderately sized abdominal aortic aneurysm involves surveillance with serial abdominal ultrasound and lifestyle modification to limit the progression. Risk factors for abdominal aortic aneurysm include advanced age, more than 60, smoking, male sex, family history, hypertension, and history of atherosclerosis, and underlying connective tissue disease. Of these, active smoking is the strongest modifiable influences for the abdominal aortic aneurysm development and progression. Smoking is believed Smoking is believed to disrupt the wall arterial wall elastin via matrix stimulation of enhanced protease activity, chronic inflammation, and smooth muscle dysfunction. And smoking cessation is considered the best intervention to minimize the abdominal aortic aneurysm progression. Because the relationship between smoking and abdominal aortic aneurysm, a one-time abdominal ultrasound is recommended to screen for abdominal aortic aneurysm in men aged 65 to 75 with with any smoking history. Okay, so the relationship between the smoking and hypertension is not a risk factor for this. Okay, maybe yes. And chronic hypertension is a risk factor for one thing. I as far I remember, dissection. Is it dissection? Dissection. Yes, maybe yes. Aortic dissection is very important topic. Yes. Okay. Conventional beta blocker which affects the beta 1 receptor metoprolol, latinolol, or both with beta and beta 2 like propanolol are associated with reduced insulin sensitivity and increased risk of developing type 2 diabetes mellitus. Hemodynamic drug effect on skeletal muscle are likely a major drivers of these findings. Normally alpha 1 receptor stimulation causes vasoconstriction, which reduces glucose uptake into the skeletal muscle due to reduced skeletal muscle blood flow. Beta 2 receptor stimulation opposes this effect. In the presence of beta blockade, alpha 1 mediated effects are unopposed, leading to further reduction in glucose uptake, higher levels of circulating glucose, and resultant increased secretion from the pancreas. Insulin resistance is effectively in, um, Insulin resistance is effectively increased. Insulin sensitivity is reduced. As a result, patient experience weight gain, a reduction in the lipolysis in the adipocyte, beta 1 receptor mediated, which largely beta 1 receptor mediated, likely also contributes to weight gain. These side effects makes an conventional beta blocker an unfavorable option for treatment for hypertension management in patients with or at high risk for type 2 diabetes mellitus. In contrast, beta blocker with combined vasodilatory alpha receptor blocking properties, uh, carvedilol, are not always associated with reduced insulin sensitivity, which provides further evidence of the importance of the hemodynamic effect on the skeletal muscle. Okay, so main thing in here is conventional beta blocker are associated with impaired glucose control, increased weight gain, likely via effect on the skeletal muscle. I'm reading the educational objective. Um, that lead to reduced insulin sensitivity. Therefore, these drugs are unfavorable option for hypertension management in patients with or at high risk for type 2 diabetes mellitus. Okay. Yes, so glucagon. Like if somebody, sorry, if somebody is taking a lots of beta blocker, it will causing hypoglycemia, severe. It will causing severe life-threatening hypoglycemia. So it can happen. So on that case, on that case, you can give glucagon. Like yes, beta blocker can cause hyperglycemia. Yes, there are there are something. What can I say? Like if somebody has type 2 diabetes, you are giving beta blocker. So what will happen in that case? It will cause masking effect. It will cause a masking effect, like a patient's sugar is low, but he is not getting the signal in the brain, because because the signal does not go due to use of the beta blocker. It is masking the patient's sugar status. So it is masking the patient's sugar status, and that's why in some condition like patients with diabetes, we try to avoid beta blocker. So it has some sort of masking effect. But uh, uh, if somebody is taking lots of beta blocker, then there may be hypoglycemia may happen, and uh, then glucagon is the drug of choice, as far I remember. But according to this explanation, they are talking about it is causing hyperglycemia because it is reducing the insulin sensitivity. As it is reducing the insulin sensitivity, so insulin is not coming to work, and thus causing hyperglycemia. I am Wait, I am looking for beta blocker poisoning. Look at the beta blocker poisoning treatment. No, I haven't found. You find. I am finding from my phone. Okay. Uh, why you are not using the AI? No, you will. be shocked when you are going to using AI. Like you search the Gemini. No, no, just write Gemini AI. This is a Gemini AI. Just click it. Yes. Okay, this is Gemini. Yes. Wait, I will give you the wonderful thing. Now go to UWorld. Just copy the whole question along with answer. Yes. Okay. No, no, you can't do it like that. Again, you go there. You just keep in the flashcard. Whatever you have copied, you keep it in the flashcard. Yes, just click the flashcard. New flashcard. Yes, 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 yes. Okay. Now paste here. Okay. So everything come. Now you copy, and now you paste. Now you can paste here. Okay. Now you click the answer. Got it? So if you don't understand anything, like just not going to random searching, go for this AI, like this Gemini. And there is another Chinese called DeepSeek. It is also good. Gemini is Google and DeepSeek is Chinese app. But DeepSeek is far better than like Gemini. They call it. Okay, I have found that special antidote for beta blocker poisoning. You search the beta blocker poisoning and you will get the answer in the Gemini. Yes. Ask. You can ask by saying to. You can ask by adding picture, like you find a dermatology problem sent by somebody of your friend or anybody. You just put it in the picture one, and you can search and you can get the differential diagnosis, lots of differential diagnosis, and then you, after that, you can exclude these and that. Got it? Okay. Now you read the explanation. No, 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 no. Just scroll down. The Gemini part. Uh, they haven't talked about the glucagon. Okay, I have found that I'm sending it. Okay, I know that some time has lost, but it will help you. Okay, the special antidote is glucagon. Glucagon is the primary antidote for beta blocker toxicity. It works by bypassing the beta adrenergic receptor and directly stimulate the adrenaline cycles. Okay, I am sending the explanation. I have sent in the WhatsApp, in your WhatsApp. As I am scrolling in the phone, that's why it's problem. Okay, read more. Just read more. Click the read more. Scroll it down. Specific antidote, glucagon. Scroll upwards. Yes, yes. That's what I am talking about. So that is the controversy. So you are talking about the glucagon part and why we are in beta blocker toxicity. Sorry, again. Yes, yes. Just like think about in this way. If you give something in a smaller amount, it will increase the effect. If you give it in a very higher amount, it will decrease the effect, like down regulation. Like think in that way. If you just slap somebody, if you just slap somebody, he will be fired in a second, in a bit of second. But if you just slapping him continuously, then then he will once he is adapted in your slapping, he will just down regulate, and he will just shutting down himself, like falling down himself. Got it? I try to make you understand in a very confusing way, but like down regulation happens. Like if you give beta blocker, if you give beta blocker, it will cause hyperglycemia. If you give lots of beta blocker, it will cause hypoglycemia. So for correcting that hypoglycemia, you need instant glucose, like glucagon. Glucagon is the instant glucose. If you give glucose and trying to correct the glucose, the patient will die. Okay. 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 Transposition of the great vessels. Transposition of the great vessel is a congenital cyanotic heart defect. Congenital cyanotic transposition of the great vessel is a congenital cyanotic heart defect in which the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. As a result, the deoxygenated blood is transported from the right side of the heart. Deoxygenated blood is transported from the right side of the heart to the body through the transported aorta, and the oxygenated blood from the lungs is returned to the lungs by the left side of the heart through the transposed pulmonary artery. After the delivery, tissue perfusion is dependent on the mixing of deoxygenated and oxygenated blood through the PDA, ventricular or ASD or patent foramen oval, which is likely the cause in this patient. Therefore, characteristics of transposition of the great vessel in newborn include cyanosis. Newborn include cyanosis within the first 24 hours, tachypnea, and single S2 on auscultation. This is very high yield. In transposition of the great vessel, there is single S2 auscultation and absent single S2 auscultation and absent pulmonary component because the aorta is anterior to the pulmonary artery. Because the aorta is anterior to the pulmonary artery, so there is single S2 on auscultation. Murmurs are atypical for transposition of the great vessel, but may be heard if a concomitant ventricular septal defect is present. Chest X-ray reveals narrow mediastinum, egg on a string appearance, and echocardiogram is diagnostic. Okay, it's not tetralogy of Fallot. It can present in newborn with period of cyanosis. If right ventricular outflow obstruction is severe, a harsh systolic murmur would be expected due to pulmonary stenosis. So we have found that in TOF usually we found the murmur of the pulmonary stenosis, which is harsh systolic murmur. But in transposition of the great vessel, we will get only single S2 on auscultation, a single and loud S2 on auscultation, no S1, sorry, no, there is normal S1 but loud S2, and there is no murmur. And this single S2 is due to absent pulmonary component because of the aorta is anterior to the pulmonary artery. So how you pick up this question? Like, what are the clue? Which clue makes you diagnose this case? Like which clue? Like single S2. Okay, so only uh, TOF and transposition. These are the cyanotic. Okay. Hypoplastic is again cyanotic. Yes. Sorry. In hypoplastic left heart syndrome, there is cyanosis, no murmur, single S2, but presentation is typically delayed a few days after birth when the ductus arteriosus closes actually, and it happens immediately within 2 hours. So yes, few days, yes. So hypoplastic left heart syndrome is another good example. Yes. Okay, it's venous stasis. Okay, the patient has chronic stasis dermatitis due to venous insufficiency. Venous stasis is common in patients who are older, obese, and who and or have a history of venous thrombosis, increased intraluminal pressure, or loss of blood, increased intraluminal pressure or loss of blood, loss of vessel wall tensile strength can lead to venous dilatation or failure of the venous valves. The exacerbates the resulting backward flow exacerbates the venous hypertension, leading to further valvular incompetence and venous congestion. Elevated venous pressure and increased vascular permeability lead to extravasation of fluid, plasma protein, or red blood cell. Clinical manifestation include scaling, weeping, superficial erosions, and pitting edema. Itching and achy pain are common but usually mild. Acute inflammation can manifest as erythema and warm resembling cellulitis. Acute inflammation manifests erythema and warm resembling cellulitis, although unlike cellulitis it is typically bilateral and symmetric. Chronic findings include red or brown discoloration due to deposition of hemosiderin, woody induration, and fibrosis. Microvascular disease, platelet aggregation, increased expression of the proteolytic enzyme can cause chronic irregular ulcer, most commonly at the medial malleolus. The diagnosis of the stasis dermatitis is usually obvious based on the clinical findings. Duplex ultrasonography. Duplex ultrasonography is not routinely performed because can confirm venous hypertension, but can confirm venous hypertension and reflux and rule out the venous thrombosis in patients with acute unilateral symptoms. Management is compression stockings, leg elevation exercise, avoid prolonged standing. Okay, so it is not necrobiosis lipoidica. Just differentiate in these it into it is necrobiosis lipoidica. There is a brownish hue, dilated blood vessel, and central epidermal atrophy. Okay, next. Okay, the clinical presentation: progressive dyspnea, fatigue, elevated BNP is progressive dyspnea, fatigue, elevated BNP is consistent with congenital congestive heart failure. BNP is a natriuretic hormone released from the ventricular myocyte in response to high ventricular filling pressure and wall stress in patients with congestive heart failure. It is derived from the cleavage of the prohormone proBNP, which produces a biologically active BNP and an inert N-terminal proBNP, anti-proBNP. Elevated levels of circulating BNP or anti-proBNP correlate with the severity of left ventricular systolic dysfunction. Conversely, normal values have a high negative predictive value for congestive heart failure as a cause of dyspnea and should prompt a search of non-cardiac causes of dyspnea. The third heart sound is a low frequency diastolic sound produced by the passive ventricular filling during early diastole. It is best heard over the cardiac apex in the left lateral decubitus position. Abnormal S3, abnormal S3 louder and higher pitch S3 gallop is commonly heard in patients with congestive heart failure due to left ventricular systolic dysfunction up to 99% sensitivity, and it correlates with elevated left atrial ventricular filling pressure and serum BNP level. Okay, why it is not periumbilical bruit? Um, and periumbilical buoy and abdominal or periumbilical buoy that lateralizes to one side can be heard in patients with renal artery stenosis. So it can be found in renal artery stenosis. So elevated BNP level and audible third heart sound are the signs of increased cardiac filling pressure and are noted in patients with congestive heart failure due to left ventricular systolic dysfunction. Got it? Okay, can we take a break for 5-10 minutes? Okay, thank you.